Good evening and welcome to our webinar on total hip replacement. I hope everyone is ready for an interesting and informative presentation. We'll get started in a moment, but first, please allow me to take a second to explain tonight's format. In a minute, I will introduce our speakers. To keep background noise down, all participants other than our speakers have been muted. And if you notice that you become unmuted at any point, because technology can be tricky, feel free to just mute yourself once more so that we can keep that background noise down. We do ask that you submit any questions via the Zoom chat feature, which you can find in your Zoom toolbar, and we do encourage questions. So please feel free to submit those at any time, and we will refer back to them during the Q&A portion. Now, for a brief introduction of OrthoSouth, we offer comprehensive orthopedic care across 8 clinic locations in the Mid-South region. We have surgery centers in both Germantown, Tennessee and South Haven, Mississippi, and we're proud to announce that our Germantown Surgery Center was recently ranked a Newsweek top ASC in America, #2 in the entire state of Tennessee. We offer Saturday clinic hours in Bartlett, evening clinic hours in our East Memphis location on Briarcrest, and we welcome walk-ins at all locations. And for those after hours injuries, we actually have an urgent care line available 24/7 that will connect you with a board-certified orthopedic surgeon ready to assist. And finally, we know you could visit any other orthopedic clinic in town, and we are so thankful when you choose us as your care providers. Our aim is to elevate your healthcare experience, and we hope you'll let us know how we do in that regard. If there's ever anything we could do to improve your experience, please always feel comfortable letting us know. And now to introduce our speakers. With us tonight, we have Dr. Michael Neel and Dr. Andrew Wodowski, who will share 2 different approaches to total hip replacement surgery and the pros and cons of both. Dr. Neel has been practicing for more than 24 years, treating adults and children with bone and soft tissue tumors, as well as treating children with bone and soft tissue tumors, as well as adults with hip and knee arthritis. He currently serves as chief for the orthopedic division at St. Jude Children's Research Hospital. Dr. Neel lectures to national and international audiences on the management of skeletally immature patients with bone cancer, the use of oncologic prosthesis in adults with massive bone loss, and the management of osteonecrosis. Dr. Neel spends his free time with his wife Liz of 30 years and 2 children, Elizabeth Ann, who is in the adult program at Madonna Learning Center, and Robert, who is a medical student. He also enjoys playing golf, following Alabama football. He volunteers at the Church Health Center and currently serves as president of the board of directors of the Madonna Learning Center, which is a faith-based school for children and adults with special needs. Dr. Waddowski is a fellowship-trained orthopedic surgeon specializing in hip and knee disorders. He focuses primarily on both hip and knee replacement, as well as revision hip and knee replacement. In his spare time, Dr. Waddowski enjoys spending time with his wife, Brittany, twin daughters, Evelyn and Emery. He participates in outdoor recreational activities such as skiing, ice hockey, running, and golf. And he also enjoys playing guitar and drums in his free time, though he tells me he did not bring those tonight. And now, without further ado, I'll let Dr. Waddowski get us started. So take it away, Dr. Waddowski.
That's great. Thanks, Melissa. Well, thank you all for being here. It's our pleasure to be talking to you this evening on hip replacement. We've got a short talk overview of what hip replacement is, how it works, what the outcomes are, what the complications can be. And then Dr. Neel and I will go to battle on our difference of opinions on best surgical approach, and that'll come later in the evening. To start off with, medicine can be confusing, and us as doctors, we're here to help. There is a lot of literature and a lot of data out there on a multitude of musculoskeletal disorders, but it's difficult to parse through. And when you're considering a hip replacement or a knee replacement for that matter, this is your journey. We're here to guide you. We're not here to push you in any direction. And that's our philosophy at OrthoSouth. We want to guide you through the process and make you feel as comfortable as process, unlike the sign would do for you if you showed up at a hospital and saw that. Next slide. So what is the hip joint? The hip joint is truly a ball and socket joint. On the left side of your screen there, you can see a model of the pelvis and spine, the top of the thigh bone called the femur. The ball is called the femoral head, and the socket is called the acetabulum. Between the shaft of the thigh bone and the ball is an area called the femoral neck. And when this joint wears out for various reasons, we treat it initially with anti-inflammatory medications, physical therapy, injections, other non-operative treatments, but sometimes it comes to a hip replacement if it gets bad enough. And what a hip replacement is, as you can see on the right side of your screen, is really where we replace the hip joint. We place a metal socket in your existing socket, and then down the shaft goes a stem, and attached to that stem is a ball. And the socket has a plastic liner, and the ball is made of various metals, and the ball goes in the socket, and it really replaces the hip joint. It moves smoothly without arthritis anymore, and it works really, really well. Next slide. There's a bunch of reasons that we do hip replacement. Those are called indications. Overwhelmingly, the most common reason to do a hip replacement is just for osteoarthritis, OA, wear and tear, regular old Arthur. There's other reasons to do hip replacement. People with rheumatoid arthritis or psoriatic arthritis or other types of inflammatory arthritis. People who fall and break their femoral neck and have a trauma can have a hip replacement to treat that. A disease called hip dysplasia, where the socket can be shallow and the ball can be small, can cause significant arthritis, especially in people who are fairly young. And a hip replacement can be for them at the end stage of their disorder. Avascular necrosis is a process where the blood supply is damaged and the bone in the top part of the ball dies. And hip replacement can take care of that to relieve pain from that disease. The final common pathway in all these disorders is joint pain. Pain is classically in the groin, down the front of your thigh, sometimes can be in the back part of your hip joint, but most oftenly it's in the groin or the thigh, worse with activity, somewhat better with rest. Now, just having one of these problems doesn't mean you have to have a hip replacement. Each one of these disorders has different parameters that can affect your need for a hip replacement. The pain can be mild or the pain can be severe and interfering with your function, such as walking, or putting on your socks and shoes, getting in and out of cars, or getting up and down from a chair at work. Some people need to use a cane when they have end-stage hip disease. The range of motion can be limited and your hip can be stiff. And then we look at x-rays to show us how much of the joint is still working well and how much is not working well. So there's a very large disparity between mild disorders and severe disorders. Next slide. Here's a classic x-ray, we call them radiographs, or x-ray of what hip arthritis looks like. On the left side of your screen there, you can see the shaft and the femur, the femoral neck and the ball in the socket with a large amount of joint space that's preserved. The clear area between the round top of the socket and the ball is all cartilage. That's a normal, good, healthy appearing hip. On the right side of your screen, you can see where the joint has been damaged. The bone looks mottled and white. We call that sclerosis. The joint space is gone. It's bone on bone. If you were to cut that open and look inside the ball, there would be cysts, which is reabsorbing of the bone. The body does that in response to the bone on bone arthritis. The hip appears out of round. It just looks painful. Next slide. Before a hip replacement, you got to go through some non-operative treatment. We don't just jump to hip replacement. We have to do certain things first to make sure you're a good candidate for hip replacement, because the fact is, a lot of people do well with these treatments on the left side. Some people can do this forever and never need a hip replacement, even with severe arthritis. The first thing is weight loss, if needed, followed by education, physical therapy to strengthen and stabilize the muscles of the hip joint. Steroid injections are a common treatment modality. Anti-inflammatory medications like NSAIDs and Tylenol are very commonly used. And then activity modification, simply avoiding positions or activities that hurt, can help you live with arthritis without having a hip replacement. The triangle on the right shows kind of how we look at hip replacement and non-operative treatment. Most people can do well with education, exercise, and weight control. Some people need anti-inflammatories and injections, and then a few people have a hip replacement. Next slide. All right, I think I'm going to turn it over to Dr. Neel here for talk about the results of hip replacement.
So thank you, Drew. Melissa, I would like to point out that you shortchanged Dr. Waddowski a little bit. He actually has 3 daughters under the age of what, Dr. Waddowski?
3 under 5, 3 under
Yes,
6.
so you deserve the extra credit for that. So, we'd like to talk now a little bit about total hip results. And truly, it's one of the most successful procedures that we do in orthopedics, and it's well known as one of the most successful procedures in general when compared to surgeries that improve the quality of life. They have parameters where they look at heart surgeries and kidney surgeries that improve quality of life, restore active years, restore patients to be able to go back to work and be productive. And it is one of the top every year of those type of procedures. So it's fantastic for getting rid of the pain, improving your motion, and restoring function. And studies have shown that if you're over the age of 50, you can expect to enjoy the new hip for a lifetime. You're very unlikely to have a revision. If you're younger than 50, the literature is starting to show similar results. So used to, when I started 25 years ago, patients say, well, you're only going to get 10 years out of your total hip. Well, that's absolutely not true anymore. If you're over 50, it can last you a lifetime. And to me, the most significant thing that I hear from my patients is that 98% or more say they wish they'd done it last year. And if they had done it last year, they would have had a year's worth of pain relief and function and being able to do stuff with their family. So most patients, 98%, are very satisfied or very happy with having had it done. Next slide. So, of course, the old guy like me gets stuck with the complications. So I've lived long enough to see all of these complications. And the one thing you need to take home is they're very, very low, less than 1%. And we break them down into 2 groups. And one is medical related. And what we refer to that as any surgery that you have, whether it's a gallbladder or a hysterectomy or prostate, whatever kind of surgery you might have, you're always subject to the risk of heart attacks and strokes and blood clots. And so what we do is we get you to meet with your primary care physician and go through all of your risk factors, whether you're diabetic, is your hemoglobin A1C where it needs to be, or you're a controlled diabetic. We look and see whether you're a smoker. We discourage smoking. We look at your weight. We try to get you below a certain body mass index, which give all of those increase dramatically the risk of complications. And so to eliminate those terrible risks of a heart attack, a stroke, a blood clot, even death, we have you meet with your primary care physician and they screen you to make sure that you're healthy enough to come and do the surgery. And luckily enough, we're doing so many surgeries now as outpatients rather than having to go to the hospital. And primarily that's because we're able to meet with your physician. We interact with them and we talk about ways that we can minimize those risks that are related to your overall general health. Next slide. So other complications include things that aren't really related to your health, like your diabetes or your heart disease, but related to having an artificial hip. And as we know, anything mechanical can break. If you've ever gone to Home Depot on Saturday morning, you've seen a host full of people there getting things to fix that are broken at home, right? And so it's the same thing with anything that we put in you mechanically, such as a total hip, they can also fail. And there's other things that happen during the time of the procedure. Sometimes at the end of the surgery, one leg's a little longer than the other, and that's related to making the hip more stable. Sometimes it's just the nature of having to do the surgery. I will tell you that most time, if there's a difference in lengths between the 2 legs, the surgery leg's a little bit longer. It's usually less than about a half an inch or an eighth of an inch, and it's well treated with a shoe lift. My experience is most patients come back and don't even remember which leg was a little bit longer. So it's very rare that happens. You can have nerve weakness, regardless of whether you do Dr. Waddowski's way through the front or you do my way through the back. You can have some weakness in the extremities that cause you to have a little bit of a limp. That usually gets better over the course of 6 to 9 months, and about 90% of the time or more, it resolves. As you see here in the x-ray, the horrible example of a dislocation. The ball can pop out of the socket. It could be from a fall. It can be from twisting the wrong way. And both, whether you go to the front or the back, has an incidence of a dislocation. And so that usually is managed by going to the emergency room and they pop it back into place. And usually more than about 60, 75% of the time, that's an isolated event. They can wiggle loose. Again, anything mechanical can break or wiggle loose. And the most devastating complication is an infection. But that's a lifetime risk. You can get any kind of infection elsewhere in the body that can seed the joint. If that happens, you have to go in, take out the implants, put antibiotics in. It's usually about a 6-month process. It's a terrible deal. And so the reason we tell you all these terrible complications is so that you're aware of them and that you don't say, oh, I'll just do my total hip and be done with it. You really have to think it through and make sure that you're medically clear, that the primary care doctor says, hey, you're good to go, and that you recognize that these risks are small, but they are real. And it does happen, but it's a very small risk. And in my experience, it just doesn't happen very often. And the better news is that we can fix almost any problem that might occur. So next slide. So talking about complications is really fun. I'm glad I was able to provide that opportunity for you. But you got to remember, it's key that the overall risk of any of these complications is less than 1% or right at 1%. And so we do things as surgeons to minimize those risks. We do things, as I mentioned, to get your primary care physician to minimize those risks. We train you to do things to minimize that risk. And so again, focus on one thing. 98% of the people that have it done wish they'd done it last year because they do so well. So while we focus on the complications in this part of the presentation, it's such a small, low risk that it's not anything to be scared of. It's just something to be aware of that you know. Next slide. So now Drew and I are going to talk about surgical approaches. There's really, as we like to say, there's the anterior approach, which he's going to discuss. There's the posterior approach, which I'm going to discuss. But as we like to say, you can get to the kitchen through the back door and then the dining room, or through the front door in the living room, but you're still in the kitchen. So whether you go through the front or the back, you're still going to have a total hip. You're still going to enjoy all those benefits I mentioned. And I tell people, don't get hung up on which direction you go. Stick with a surgeon who's confident and likes to do it the way he does it.
That's great. Thanks, Mike. Yep. Thank you so much. Good talk there. So approaches just means how we get to the hip, just like Mike said. Any way you go, you'll end up in the kitchen. You're going to have a total hip. You're going to get all the benefits from a total hip. And the two main ways to do a hip replacement these days are probably the direct anterior approach and then the posterior lateral approach. Those are the formal names. We'll refer to them as anterior and posterior, but really they're both on the side. One's just a little towards the front. Anterior one is visible in the mirror if you were standing in front of a mirror, and the posterior approach is not visible in the mirror. They're kind of on the side. One airs towards the front a little bit, one airs towards the back. They're not really in the way front by your belly button and the way in the back, but they're more on the side. There's advantages and disadvantages to each. And then based on training, experience, and preference, we choose what we think is best for you. Next slide. So I am a direct anterior surgeon. I also use the posterior lateral approach like Dr. Neel, but I really like the direct anterior approach for a multitude of reasons. So it's really a true internervous and intermuscular plane. We go between the muscles, and those muscles are controlled by nerves. And the path that we take to get to your hip is between the muscles that are controlled by different nerves. It's great. So there's no splitting of muscles. There's no splitting of nerves. There's no loss of muscular control. It would be extremely rare for that to happen, loss of muscular control in the direct anterior approach. Another advantage is that I can use fluoroscopy, which is a special type of x-ray where I can see real-time x-ray in the operating room. And it allows for me to put the stem and the cup and the ball in the ideal position. And that's probably the main advantage. We know that big cause of hip failures is due to positions that are outside what we call the safe zone. And really using x-ray and allowing it to move and customize the parts to your pelvis really allows me to get the components in the perfect position. There is in the literature a reported lower dislocation rate from about 3-to-1 ratio if you would go that high in some studies. But really the dislocation rate, like we talked about a second ago, is less than 1%. There's a lower dislocation rate in the direct anterior approach, however, because the posterior capsule is not damaged. And kind of Mike will show what that means a little bit later. There's a suggestion that the anterior approach carries with it easier early rehabilitation or a shorter length of stay in the hospital. This has kind of been borne out in the literature over the last 10 or 15 years. The direct anterior approach is not new. It's been around for a long time, 40 years, but it's really established a resurgence in a lot of training programs and in the literature of the last decade with the advent of hip replacement at surgery centers, people going home the same day. And so we look at the early literature, talk about 3 months after hip replacement, and it's been shown, suggested in the literature that the direct anterior approach, because there's no muscle splitting and because there's a slightly lower dislocation rate, might carry with it earlier return to normal function. That literature has been borne out early, but as you'll learn later, at 1 year, the difference in either approach is just about the same. Next slide. Another picture of their direct anterior approach there, kind of towards the front on the side of your hip. There are some disadvantages though, and direct anterior is not for everybody. So in those patients, I'll choose to use Dr. Neel and the standard posterior lateral approach. There might be a suggestion in the literature that there are higher wound complications. The blood supply to your skin and the fat under your skin and the front part of your hip is not as robust as the back part. And so we think that there might be a little bit of wound healing problems, higher fracture risk because of the exposure difficulty. It's harder to see. There's no doubt about it. It's a smaller incision. The muscles are tight going this direction, and it's just tougher to see. Fortunately, with x-ray and fluoroscopy, we can do the surgery 99% of the time without any problems, but there's no doubt about it. It's tougher to see. And so with that comes a little bit more pulling. And so we think that there's a slightly higher risk of fracture that could be either of the pelvis or of the top part of the femur. These fractures aren't where your bones split in half. We think of them as either little avulsions where muscles kind of rip off a fleck of bone, or a little crack that can usually be fixed by a cable or maybe even sometimes a small plate. These fractures usually are not extremely detrimental. They don't really compromise recovery. Occasionally they can, but nonetheless, they're still fractures. And then need for special equipment. Some people that do the direct anterior approach require a special bed called a HANA table. There is risks and benefits to using the HANA table. I choose not to use the HANA table, can use a regular operating room table that you can use, that you can see x-ray through. But there are certainly a need for some special retractors and custom instruments to help really facilitate your way around the hip using this approach. Next slide. So again, why do I prefer it? Intraoperative x-ray. Here's a great picture right there on the right of what I can see literally at the time of surgery on x-ray. I can see the stem, I can see the socket, I can see where I put everything, and I can make micro adjustments to x-ray, I can make micro adjustments to the components, and it all happens pretty much in real time. Within seconds, it's just taking another quick little x-ray. The machine kind of hovers over your body, and the x-ray person that takes the pictures just pushes a button and it takes another picture. It literally takes seconds. So I can make adjustments on the fly. Again, lower dislocation risk potentially, faster, earlier rehabilitation potentially. But again, as I just said, and you'll hear from Dr. Neel again, there really is no difference between either the anterior or the posterior approach at 1 year. They're both the same. You're going to enjoy the benefits either way. It's just how you get there. Next slide. All right, Mike, take it away.
So thanks, Dr. Waddowski. Everything you just said is fake news. Don't believe any of it. This is the real story from here on out. Like Drew, I'll be talking about what is the posterior approach, what are the advantages and disadvantages, and why I do it. Next slide. So the posterior approach is what we think of as the, quote, original approach, the way total hips have been done for more than 50 years. And as he mentioned, the approach is through the side of the hip, more towards the back, and we like to refer to as kind of the back pockets. And the surgeon enters the hip joint through the back of the posterior side of the hip where it gets its name. Next slide. So recently, the traditional way was we took down a lot of muscles. We took the gluteus muscle, the big muscle of your buttocks, and released it, and some of the other muscles off. We basically stripped the whole back of the hip joint of all the soft tissues, which then had to be repaired, and then were subject to weakness, which caused frankly a high dislocation rate, unacceptable dislocation rate, which when the anterior guys talk about you got a high dislocation rate, they lump those older versions in there sometimes. What we have adopted now is what we refer to as a tissue sparing approach. We use a smaller incision, although the incision is not as important, but we do dramatically less muscle releases. The larger muscles, the buttock muscle, we open the very top of them, and then we tease apart the fibers and we open them up like a curtain. And so we don't cut them in half. We just open them up. And then at the end of the surgery, we do our work. And at the end of the surgery, we close them and just stitch the very top of it back down. And so there's not a whole lot of muscle damage like we used to do. It results in an ability to recover quickly and rapidly, a lot less postoperative pain than the traditional posterior approach. And it allows for quick mobilization. And as I mentioned earlier, same day surgery, we're able to do that quite well. So it also results in a very low dislocation rate, which I believe, and the studies have borne out, this more tissue sparing approach is very similar to the same dislocation rate as in the anterior approach. So I think the way to look at it is we were comfortable the way we used to do it posteriorly, and we did it the way we did it for years. And then we started looking at the anterior approach and said, wow, we can do better than what we're doing. And so we changed what we did. And thank you for the anterior approach surgeons, because we made a difference and changed it, which I think has dramatically improved it and equalized the results. Next slide. So as you see here, the way on the right, which you see with the big X, was the way we used to do it. A big incision, we take down all the muscles so you could see the whole joint all at once. And now what we do in the tissue sparing, we have a smaller incision. We're able to move that incision, kind of push it this way, push it that way, and see what we need to see, and able to put a nice total hip in and do the entire surgery through a much smaller surgery without all the tissue damage that we used to do, which gave the posterior approach the bad name that it did. Next slide. So to me, what are the advantages? Well, I agree with Dr. Waddowski. Intraoperative x-ray is key to getting the x-rays, getting the total joint in the exact position that you want it. And I, like Dr. Waddowski, use intraoperative x-ray. I didn't realize it was specific to the anterior approach because we've been using it forever with the posterior approach. So I too get x-rays intraoperatively and make sure that my components are in the right position. I make sure my leg lengths are equal, which you can do with the x-rays that we take intraoperatively. So while the radiology x-rays intraoperatively is very important, it's certainly not specific to the anterior or the posterior approach, but it is very helpful. I mentioned already, the advantage to me is the less muscle release, the less post-op pain, quick early mobilization. Most of my patients go home the same day for doing outpatient, or at least the next morning. They're driving by 2 or 3 weeks, return to work, depending, 4 to 8 weeks. And most people say, hey, Dr. Neel, I feel like I'm over the surgery. And it's about 6 weeks. Long term, we let them do activity as tolerated. Next slide. So the disadvantages, early on, we do limit your we do give you positional restrictions. We don't want you flexing the hip up too high because that's subject to dislocation, tearing the little repair that we've done. And we limit you how much you cross your legs. And you sleep with a wedge between the pillow for the first 4 weeks. After that, I pretty much let you do whatever you want to do activity-wise. We don't restrict you how much you can bend and move. And since we do the much smaller tissue-sparing procedure, we don't have to limit you as much as we used to. And so the restrictions are very low. So the disadvantages, to me, it's that early positional restrictions, pretty much the biggest disadvantage. Next slide. So why do I still do it? Or as a lot of patients ask me after they've seen Dr. Waddowski, they come and say, well, why do you still do it? That thing can't work. He's young, he's smart, he's out of his fellowship. Why do you still do that old school thing? Well, I do it because it works. It's worked for 25 years. It works for me. It works for my patients, and it works for their families who have to take care of them in the post-op period. They rehab so quick. They get along so well. I did the anterior approach for about a year or more, and I couldn't see, for me, a big difference in the way I was doing the old posterior, the new tissue sparing posterior approach. And so they seem to have the same length of stay. I rounded on my partners, not Dr. Waddowski, but other partners who did it anteriorly. And I couldn't tell a difference between when my patients went home and their patients went home. And so to me, they had the same length of staying, same post-op pain levels, return to work, return to activity was the same. So I looked at the disadvantages of the posterior approach, compared them to the anterior approach, and decided I'm a really great posterior approach surgeon. I'm going to stick with it. So that's why I still do it. Next slide. Thank you. Thank you.
All right. I feel as if Dr. Waddowski, do you have any rebuttal there for the anterior?
You know, there's not really a true rebuttal. There's no rebuttal, because I'm going to be the first to admit it. Anterior approach to me is not for everybody. There are some people that say, yes, anterior approach is for everybody. But for me, I'm fairly selective. For most people, I'll use the anterior approach. For some, big deformities in their hip, weird anatomy, or previous infections or problems where we think we might have to go back, I'll be a posterior approach surgeon. There's no question in my mind that tried and true posterior lateral approach is still awesome. But I do think that I can give a benefit to my patients for the people who I think will get a benefit out of the anterior approach. And that's, the physiologically younger patient who want to get up, move quicker, and get back to activity as fast as they can. But again, the tissue sparing posterior approach can do the same thing. So I prefer the anterior approach. I feel that I'm good at it. I like having intraoperative x-ray that's quick. And so that's why I do it. But again, Dr. Neel, posterior lateral approach, wonderful, tried and true, awesome thing. And I do it too. So that's it. That's what I got.
I would echo the same thing. The most important critical piece is to allow your surgeon that you feel comfortable with, that you've established a relationship with, who you like, who you want to do your surgery, to let that surgeon decide what they want to do, what they're best comfortable with, what they believe in, and whether it's anterior or posterior, then at the end of the day, I don't think it really matters. You want your surgeon to be comfortable doing the kind of surgery they want to do.
Exactly. Well
Fantastic, gentlemen. Thank you so much. And now, everyone, we are moving into the question and answer portion of the webinar tonight. If you do have any questions, please feel free to type those into the Zoom chat box, which you can find in your toolbar. I do have a couple of questions that have already come in, and I will start with this first one. If someone has already had a hip replacement and they've gone through physical therapy and home rehab first, then physical therapy, but they still have pain, this is 4 months later when they go upstairs, rise from the chair, turn over in bed, is there something else they should be doing? And what would you say to that? Dr. Neel, would you like to take that one?
Sure. I'm sorry, you broke up just a little bit. So I think
I
the question is,
apologize.
at 4 months, oh, you're good. I think the question is, at 4 months post-op, still having some pain, getting it up and down out of a chair, things like that. A lot of times it depends on the patient and your activity level. A lot of times you're a victim of being very energetic and want to get out and do, and your hip's slowing you down. If you're 80 years old and sitting on the front porch, you may not have that kind of problem. And so I find a lot of patients who have that problem at 4 months, and 4 months is early post-operatively. I tell my patients it's a big bell curve, and some patients are over the surgery by 4 months, 3 months, some at 6, even 9 months. It just kind of depends. But I find a lot of times the rehab early on is designed to get you from the bed to the chair to the bathroom, just puttering around the house. And if you're really active and wanting to get out and do stuff, that may not be sufficient rehab to get you back. And sometimes at 3 months, 6 months, we take you back to physical therapy and focus more on strengthening and gait training more than we just did getting you to the bathroom and the shower. We're working really on strengthening you. And a lot of times you have to regroup and do a little bit more therapy like that. And that usually takes care of that problem.
Fantastic. Thank you. Dr. Waddowski, do you have anything to add?
Yeah, I'll add to that. I want to add one thing that I tell my patients, and that, by 3 months out from a hip replacement, you're probably on average 80 to 85% of the way through your full recovery. But that 80 to 85% is significantly better than you were. That last 10, 15, 20% comes over the course of, the next year after those first 3 months. And so overwhelmingly, having symptoms of pain when you go up and down stairs, when you roll over in bed, if the hip is not overall better than it was before, then go talk to your doctor. But really, that comes with time. And some things just take a long time to come back. But overall, at 3 months, 85% of the way there, still expect to have maybe a little bit of twinge every now and then. But it really can take a full year to fully 100% get over your hip replacement.
I Excellent. Fantastic. The next question says, is recovery for can you do both hips at the same time?
I can take that one. And the question is, should you do both? If you have two bad hips, should you do both of them at the same time? And I think it's not like knees, where some people are still performing both knees at the same time. A hip it can be a pretty large physiologic hit. And what I mean by that is that there's potentially a substantial blood loss or substantially more blood loss associated with a hip replacement. And doing two can be tough on your body. Can it be done? Absolutely, it could be done. Do we recommend it? No, because it can be a pretty big physiologic hit. So we would do one, and then 6 to 8 weeks after, plan for the other one.
I would agree. It's certainly doable. Not so much the posterior approach, maybe more doable with the anterior approach, but I don't see any great advantage. And most of my patients who need the second hip done, they come back at 2-3 weeks and they like, oh, I'm glad I'm not ready to do the other hip. Or they come back and say, let's go ahead and schedule the other one, and we get it done within 2 or 3 months. And so there's not a huge advantage to doing both at once. And there's lots of disadvantages, that Dr. Waddowski said.
Great, thank you guys. Next question is recovery for the anterior approach similar to the posterior approach? Dr. Neel?
Yes, of course. No, I believe it is. I think Dr. Waddowski is right. I think there's some studies out there that may indicate the anterior approach gets you back a little bit quicker. In my experience, I think they're the same. When I was doing it anterior and doing it posterior, I didn't see a difference. I think as early as 8 weeks, I think it's the same. I think it's probably the same at 3 or 4 weeks. So I think it's what rehab really and recovery depends on is it's not so much the approach again, and we keep reiterating this. It's really your motivation. It's your ability to do the physical therapy and do the rehab. Some people are able to do it very aggressively, and some people it just takes a little bit longer. And so I think it's less dependent on the surgical approach and more on factors such as your motivation, your willingness to put in the time and do the therapy, your other medical problems you might have could slow you down. And so, but I don't see a big difference between the two.
Yeah, I would totally agree. I would 100% agree with that. I don't think really the approach is the difference maker. I think what the difference maker is the patient. You have somebody who's 80 or 90 years old who has been in, the only activity they've done for the last 20 years has done some gardening, or you've got the 50-year-old triathlete. And there's no question that the 50-year-old triathlete is probably going to jump up quicker than the 80-year-old gardener. There's no question, regardless of approach. So while the literature would maybe suggest some early advantages to the anterior approach, I really don't think that that is the key feature. I think it's patient-based. And we recognize that and we realize that, and we're going to get you through it one way or the other.
You got to be careful, dear. I've seen a lot of 89-year-old gardeners that run circles around 50-year-old men like me.
80 is the new 60,
Thank you, guys. Next question, is there any contact with the stomach wall during surgery, during either approach?
I guess I can start. Yeah, I can
Not
start.
Posteriorly.
And take that. Yeah, it would be very unlikely in the posterior approach. The only thing I can think of with the stomach wall would be the positioners on the table that we kind of use to position you with the posterior lateral approach, but no contact with any surgical instruments. On the anterior approach, yeah, there can be some contact to the front part side, right under your ribs. In order to get the stem down your thigh bone, we have to extend your leg back out. If you can imagine laying supine on your back on the operating table and having the leg that we're doing kind of go behind you a little bit, straight out back, you can imagine drawing a line right down your thigh bone would kind of go right towards the rib on that same side. And so it's rare that we come in contact with your stomach wall or your ribs, but sometimes in somebody who's got a really tight hip, yes, that handle or the retractor can make contact there. It's extremely rare, and I wouldn't anticipate it to cause any problem.
Excellent, thank you.
Sure.
If someone has had those stomach surgeries, would that be better would you try to avoid that with that patient?
It depends where the scars are. That's a great question. So the question is, if you've had previous surgery in that front kind of bottom part of your abdomen, can you still do an anterior approach? The answer is, it just really depends on the scars are, what those surgeries are. But yes, people that have had tummy tucks, hernia surgery, cardiac catheterizations through their groin and the artery there, it usually is not in the way, and anterior approach is just fine.
Excellent. Next question, Dr. Neel, can both of these approaches be done same-day surgery? I heard you say the posterior multiple times being done same day, but can anterior be done as well?
Absolutely. It's a great way to do it. Either way could be done anteriorly. And a lot of times done same day. A lot of things that determine whether you can go same day surgery is, again, your overall health. People who may be heavier or diabetic or have a history of heart stents or things like that, those are ones we steer away from doing at the outpatient setting. But regardless of the approach, you can do it same day. Absolutely.
That's right. All the things we need for either approach we have at both of our surgery centers.
Excellent. Thank you. Our next question, someone with mild dysplasia and some arthritis has a limp that's really slowed them down and really bothers them. At almost 70 years old, they're wondering if they can get this done as an elective surgery since insurance would not cover it. Can either of you speak to that? Dr. Waddowski?
Yeah, I can start and take that one. I think first and foremost is to figure out what the cause of the limp is. And so I think what I'm hearing is the question is, somebody who's 70 years old, is insurance going to cover them if they need a hip replacement, and are they qualifying for a hip replacement? The first thing to do is to let us take an x-ray of your pelvis and your hip and see what's going on in your hip joint. Limps can be from a lot of different things. Limps can be from issues with your back. Limps can be with issues with your knee or your ankle or other things. And it's our job to figure out if it is really coming from your hip. Now, if it's coming from your hip, absolutely, and it's causing you a limp and pain, and your hip is arthritic or has another one of those disorders, absolutely, hip replacement we can do, and we'll help you any way through we can. Insurance or not, we'll help you any way through we can. But it's really our job to figure out why you're limping. And I'll tell you, there's a lot of different things that can cause a limp, and it would be really bad if we just did a hip replacement and it didn't fix that because it was due to something else. Dr. Neel?
Excellent.
Absolutely. That's exactly right. We could put a shiny, new, pretty total hip either through the front or the back. And if your pain and your limp's coming from a degenerative lumbar lower back spine, we're not going to help you very much. So you need a real thorough evaluation of what the cause is.
Thank you. And for our audience, I have one more question here, and then if we have no others, we'll wrap up. So please feel free to add your questions to the Zoom chat if you have any others. My next question is there a best age range, a target age range that you try to hit, as far as you try to avoid hip replacements in these folks who are too young, or these folks who have maybe aged out and where the risks are too high? Dr. Waddowski, can you speak to that?
Yeah, I think I can start this one off, and then I'm sure Dr. Neel has some stuff to say with his work at St. Jude. I think that really, no, there's not an age that is prohibitive of having a hip replacement. There are certain things that cause the hip to be destroyed in very young age or very old age. And again, it's our job to figure out if you're a candidate for a hip replacement. So while age does play a role, because the younger you are, if you have a hip replacement, the greater likelihood of you needing to have a redo hip replacement when you're older, and vice versa. The older you are when you have a hip replacement, the less likely you are to need a revision or a redo at all. And so that's really the only factor. And you just need to be aware of that when it comes time for your hip replacement. It's not like if you're 22 years old, it's not like we're going to make you limp around for the next 30 years till you get to a certain age before we do a hip replacement. That's not right. And that's not our job to do. we want to do what's right for you, and not everyone has the same story, and all these disease processes progress differently, and we'll do what's right. Again, age is just a number, and people, as we're living longer, becoming more active into our older age. As people get up there in age, it's not uncommon to do hip replacements on 80, 90-year-olds. And I mean, I know Dr. Neel and I have both done a few 100-year-olds. So there's really no age cutoff, if that makes sense. Dr. Neel?
I would agree 100%. I just, you mentioned St. Jude. We just published our recent results of about 50, 60 patients at St. Jude. The average age is 18. And those patients receive steroids and chemotherapy, which damages the hip joint. And they're miserable. Their hip's arthritic, and they look like a 90-year-old arthritic hip when they're 17. And we do hip replacements on them, and they do fantastic. They're able to go back to school, go back to work, and live very productive lives. When I started 25 years ago, you never operate on anybody less than 65 because it wasn't going to last very long. Well, we're not so dogmatic about that. As I just said, we do them in 18-year-olds when you need them, and we do them in 90-year-olds when you need them. And it's really the health of the patient, the motivation of the patient, how much they are able to do and participate in the rehab. That's what's the most important thing. And we don't worry so much about the age as we do the indications. How bad do you hurt? Do you need to have it done? If you're 17 or you're 78, that's fine. And if you're healthy enough to do the surgery and it's safe from that standpoint, regardless of the age, then you're a candidate. And the biggest thing, as I mentioned earlier, is the complications. At whatever age, you have a different set of complications. As Dr. Waddowski mentioned, my young patients at St. Jude have a lifetime risk of infections and problems and mechanical failures and all that, as opposed to the person who's 85 who has a lot less time to have complications. And so as long as you recognize the complications and you realize that there's a possibility, age really doesn't matter. It's the surgery can be successful at any age.
Great responses. Thank you so much. And the last question I have right now, unless someone has one more to sneak in here before we adjourn, is about pain management. Postoperatively, can you guys speak to what kind of pain management is offered, and is this typically a very painful surgery? Is recovery painful? Dr. Neel?
So I speak from a very unique perspective. I had a total hip done a couple of years ago, and I'm not a tough guy by any stretch of imagination, but thanks to a multi-modality pain approach with different medicines pre and post-op, now it's mainstream, it's what we do all the time. The strongest medicine I took was 800 milligrams of ibuprofen, basically just Advil. Now, did I hurt a lot some days? Sure. Did I have trouble getting around the house the first week? Sure. But I was on a walker and then a cane very quickly. And the most I ever took was the ibuprofen. I'd say we try to stay away from the opioids now. And Dr. Waddowski can elaborate, but we have about a 8-drug regimen that we give perioperatively. We do a lot of nerve blocks that we didn't do even 5 years ago that help to numb up the whole hip joint. And really, most patients will get up and walk around. Like we mentioned, same-day surgery. Those patients get up and walk around the recovery room, and they don't go home till they're able to walk independently with a walker. And so the pain control is much better than it used to be. And thanks to these modalities where we had a bunch of different medicines over a period of time, it really does minimize the pain, and it makes the return to function so much quicker. It's going to be painful. Don't get me wrong. I'm here to test. It does hurt. Some days worse than others, but every day gets better. As my patient told me one day, before surgery, I knew I needed to have surgery. After surgery, I knew I'd had surgery, but my pain was getting better every day.
Yeah, I'll elaborate on that. Yeah, I'll elaborate on that just a little bit. I think what I hear most from my patients is that, it feels different. Yes, it hurts, but it's a different hurt. Most people come in, they say, oh, it's my groin. It's a grinding pain. It's dull. It's a toothache deep in there. Gosh, it just won't go away. And we do the hip replacement. And then the next, later that afternoon, they say, wow, yeah, it hurts different. It hurts over here on the side, but my goodness, that pain in my groin, that's gone. That's great. They can get up, they can walk, they can move. Answering the question further, there's really three, what I look at is kind of three time frames of pain after hip replacement. And the first is right away when you wake up from the anesthesia. The second is the first 36 hours or 48 hours. And then the last is the first couple of weeks. We do a bunch of things. Dr. Neel mentioned multimodal anesthesia. And the first thing that we try to do is a spinal anesthetic. And as that gently wears off, as you wake up in the recovery room, your pain right after surgery is not like a brick hitting you as you would have with the general anesthesia. When you wake up and all that pain is there, the spinal anesthetic wears off slowly. It's a gradual introduction to that initial postoperative pain. And we have medicine on board that helps control that anyway. The first 36 to 48 hours are controlled really well with what we call periarticular, which is around the joint injections, as Dr. Neel mentioned. Combination of long-acting anesthetics and some anti-inflammatories injected into the tissues around your hip do pretty well for the first couple of days when the pain would be at its worst. And then the first couple of weeks, we try to get everybody on a scheduled regimen of Tylenol and an anti-inflammatory NSAID medication. We supplement that with some nerve pain medications and some aspirin. And then if you need more on top of that, we give everybody just some light narcotics such as Percocet or hydrocodone and a little bit of tramadol, which is a non-narcotic, narcotic-based medication. Very confusing there, but it's not quite as strong or as potent as the narcotics you've heard in literature. Honestly, there's a lot of people that don't even take but one or two of the narcotic pills, and some not at all. It's great. It's come a long way in the past, decade when I started training.
Excellent. Thank you so much.
You're welcome.
Our
These
next
are great
question
questions, by the way.
Yeah, absolutely. I do have another question that has popped up. Do joint supplements help? I'm not sure whether that is asking specifically, do they help with the hip arthritis or postoperatively, but I will let you guys take one or both of those angles. Dr. Waddowski,
Sure.
you want to start?
Yeah, I can start. I think early on for just a diagnosis of regular wear and tear osteoarthritis, I think that the joint juice supplements, glucosamine, chondroitin, MSM, I think they can help a little bit. Are they going to keep the structure of your hip, integrity there? If you continue to run, marathons or continue to do CrossFit and you have a little arthritis, the answer is no. They're not a magic bullet. They're not a be all. They're not a be all end all. And so I think early on in the process, taking them really poses very little risk. And I tell my patients that it's totally fine to take it because there's very little risk and the potential upside is great. Later on in the process, when you have bad arthritis, bone on bone, or bad inflammatory arthritis, those medications really won't do much. And at that point, I think it kind of becomes not necessary to take them. Dr. Neel?
I would agree. I find a lot of patients swear by their supplements. You mentioned a few of them. I've known orthopedic surgeon colleagues of mine who swear by theirs, and they have bad arthritic knees and hips, and they take it, and they say, that's the only way I can keep working. And so I think some people do get benefit from it. I think as a supplement, they're not as well studied scientifically. So we don't know which ones really work and which ones are just a placebo that make you think you're getting better. So I tell patients early on, as you mentioned, to try it, because we want to do everything we can to not have to replace your hip and to try it. And if you're taking a supplement and after 3 months you stop it and you can't really tell a difference, well, you probably just need to save your money and do something different. If you stop it for a week and you can tell a big difference, then it's probably worth getting back on it. And if I knew which supplement worked for which patient, I'd prescribe them all the time, but it's really hit or miss is the problem. And so I try to encourage patients not to get sucked down there. I'm going to take my glucosamine every day and my hip hurts like heck and I wish I'd get it fixed. There comes a point where if your hip arthritis is bad enough, the medicine or the supplements are just not going to help.
Great. Well, I believe everybody, we have come to the end of our session. Thank you so much for joining us. Doctors, I would like to ask if you have anything to say in closing. We'll take just a couple of minutes before we adjourn completely. Dr. Neel, do you have anything you'd like to say?
I'd say thank you all for attending and for your questions, very great questions. And thank you for supporting OrthoSouth by getting on our website and seeing the webinar. We appreciate it. And hopefully you'll come see us at OrthoSouth if you have a hip problem, and either Drew or I will be glad to take care of you, or Dr. Patterson, our other total hip surgeon. Love to take care of you and your family. And if you come, we'll treat you like family.
I'd echo that. I'd echo that 100%. We'll treat you like family. We'll give you your time. We'll answer all your questions about whatever you have about hip and knee replacement. You know, another thing is that Dr. Neel and I work closely together. We do a lot of surgery together at times. And, you know, if you're a patient that has a rare problem or a big problem, we'll work together. And so, you know, we like doing this. We like talking about it. We're going to give you, you know, the best treatment you can find in the city. So come see us and we'll treat you like family.
Thank you. Thank you so much, gentlemen. And to our participants, this webinar it has been recorded. It will be available on our website and via our social media channels. If you have any friends or family who need to see it, just feel free to send them our way. Always feel free to call us to ask any questions or to make an appointment with one of these fine doctors. And feel free to send any additional questions my way to mkandel@orthosouth.org. Anytime. That's mkandel@orthosouth.org. Thank you and have a great evening.
Thanks, Melissa. Thank you, everyone.
Thank you all. Yep. Thank you very much.